pulse for management of a posterior polar cataract. After doing routine steps and staining the anterior capsule with Blurex, we are proceeding ahead with CCC. The size of continuous curvilinear capsular axis should be adequate enough. Ideally, it should cover 0.5 mm of the optic edge of IOL. In case of any PCR, it supports the placement of 3-piece in sulcus IOL. Hydrodelineation is the procedure we prefer to do in cases of posterior polar cataract because it leaves behind a protective epinuclear cell. While doing the phacoemulsification, direct chop method with lower parameters of phacosetting is preferred. It's done very slowly. Before removing the phacoprobe, we must inject viscoelastics so as to prevent any chamber fluctuation during the surgery. Viscodissection of cortex is preferred so as to avoid any PCR. Now, epinuclear setting is being used to emulsify and aspirate the epinuclear cell very slowly. At any step before removing the phacoprobe, viscoelastic must be injected through side port so as to avoid any chamber fluctuation and subsequent risk of PCR in cases of posterior polar cataract. The second instrument should be used freely to move the epinucleus or remaining cortical matter, whichever is free. The phacoparameter should be low enough. While doing irrigation and aspiration around 360 degree, try to separate the cortex from the capsule and leave the central posterior plaque undisturbed. The goal is to aspirate the posterior polar plaque at the end so that even if there is any impending PCR or pre-existing PCR, the cortical matter has been aspirated already. Again, This irrigation and aspiration needs to be done very gently. While changing hands, we must make it a point to inject viscoelastic before removing the irrigation probe so as not to disturb the chamber height. While injecting IOL, again the risk of rent is there because there is weakness of posterior pole. So it should be done slowly.